Sehr geehrte Damen und Herren, mein Name ist Falk Dukatz und ich bin für das Unternehmen AgNovos Healthcare tätig. Ich begrüße Sie im Namen des Unternehmens herzlich zu unserem AgNovos Satellitensymposium Local Osteo-Enhancement Procedure Addressing Unmet Needs in Osteoporosis Treatments. In der kommenden halben Stunde stellen wir Ihnen einen neuen chirurgischen Therapieansatz in der Osteoporosebehandlung vor. Unser Verfahren verwendet ein triphasisches, resorbierbares osteokonduktives Implantatmaterial zur Stärkung des proximalen Femurs. Wir freuen uns ganz besonders, Ihnen für unser heutiges Symposium zwei spannende Vorträge ankündigen zu können. Zum einen von Herrn Dr. Brian Huber aus Vermont, USA, gefolgt von Herrn Dr. Jode Skepper aus St. Nicholas in Belgien. Dr. Huber wird Ihnen das Verfahren als auch Ergebnis der klinischen Proof-of-Concept-Studie vorstellen. Im Anschluss präsentiert Ihnen Dr. De Skepper aktuelle Erfahrungen aus der Anwendung dieser chirurgischen Therapie in seiner Klinik. Viel Vergnügen.
OSSURE LOEP is a minimally invasive local enhancement procedure designed to treat osteoporotic bone loss of the proximal femur. My name is Brian Huber, and I'm an orthopedic surgeon in Vermont, and I was the initial principal investigator for the OSSURE LOEP proof of concept clinical study. It is a real pleasure to discuss this transformative treatment for osteoporosis today. Osteoporotic bone loss continues to affect millions of individuals worldwide, with devastating consequences and a massive burden for both patients and healthcare systems. Although there are important systemic therapies available, these treatments have not significantly mitigated osteoporotic hip fracture and are clearly not a complete solution. In fact, in the first month after hip fracture, there is an 11 times greater risk of a second fracture, and this risk remains twice as high over the next 3 years. Despite this risk, only a small percentage of hip fracture patients truly get started on systemic treatment, with a 9 to 18 month lag to gain any protection with systemic treatments, combined with a low compliance rate and the persistent risk of hip fracture. Novel treatment approaches like LOEP have a clear role and should be considered in the future treatment paradigm for osteoporosis. One potential local approach that has gained interest from many clinicians over the years involves surgical reinforcement of fragile at-risk proximal femurs. Is this really mission impossible? Can it be accomplished? In an article from 2016, Varga clearly outlined the criteria for a successful surgical solution. 1. Significant immediate mechanical strength needs to be gained. It needs to be minimally invasive, clinically feasible, ethically and financially acceptable. Although this is a tall order to satisfy all of the requirements, there is such a huge unmet need demanding an attention for a solution. AgNovos Healthcare has developed a promising surgical treatment that I will describe to you today. The treatment involves a minimally invasive procedure using a CE marked kit. The device is intended to address bone loss, including bone loss in the proximal femur of patients with osteoporosis. The procedure involves the creation of an enhancement site within the proximal femur, which is prepared with gentle debridement and thorough suction irrigation. A unique triphasic material called OSSURE is then injected percutaneously into the site. The material hardens, increasing the femoral strength immediately. As the material is resorbed, it is rapidly replaced by new bone, providing durable 5+ year increased femoral strength. The procedure is performed on a standard fracture table with fluoroscopy. A percutaneous guide pin and drill are inserted into the femoral neck. Inspection and gentle debridement of the enhancement site in the proximal femur is performed. After thorough suction and irrigation to clear the site, followed by filling of the defect site with the OSSURE material. The proof of concept study was a prospective cohort. The study was reviewed and approved by an institutional review board and conducted in the United States. 12 postmenopausal women participated. The left hip was treated and the right hip was used as control. There were 2 phases of follow-up, the first at the 2-year mark and the second between 5 and 7 years after treatment. Both safety and efficacy endpoints were included. For safety, we assessed the procedure and the device via adverse events. For efficacy, we measured bone mineral density as assessed by DEXA scan. CT scans were also conducted preoperatively at 12 weeks, 24 weeks, and at the extension time point 5 to 7 years. The inclusion criteria: female, over the age of 55, postmenopausal at least 1 year, and DEXA scan T-scores of -2.5 or lower at the femoral neck. Exclusion criteria included previous hip fracture, renal insufficiency, and other conditions the investigator believed would disqualify the patient from the study. All 12 patients provided consent for the study. 10 were available for the full imaging workup and throughout the study to closure. 2 patients were unable to visit the site for the CT scan at the latest follow-up time point. There was a wide range of age from the youngest 56 to the oldest 89. There were no restrictions on systemic therapy during the study, and more than half of the group had prescriptions for osteoporosis medications at the start of the study. 6, in fact, were on bisphosphonates and 1 on hormone replacement therapy. This slide demonstrates the injection of the OSSURE material. The average injection volume was 19 cc's, and the average skin-to-skin surgical time was approximately 20 minutes. Here we can see the x-rays and the CAT scans of one of the patients. In the preoperative image, we can see a lack of cancellous bone in the femoral neck. This is a common finding in people with osteoporosis. Another observation is that the implant material is resorbing and being replaced by bone. The majority of it has been replaced with bone by 6 months. What's also evident is that the treatment effect is highly localized. Bone is being formed where the OSSURE material has been implanted. And furthermore, the new bone is still present at the final endpoint up to 7 years. As we look at the scans of another patient, we see a very consistent treatment response. Resorption and bone formation are closely coupled, and substantial new bone has been formed as early as 6 months. For this patient, what we find interesting is what happened to the material that was injected further inferior towards the diaphysis. In this region, with less mechanical loading, the material resorbed without accompanying bone formation, as expected given Wolff's law. More proximally, though, between the tensile and compressive trabeculae of the femoral neck, we do see bone formation, which is durable and lasting even at 72 months. So, based on this, we believe that the material is responding to the mechanical stresses in the same way as normal bone would. Here we see the bone mineral density for the treated and control femurs, with the percentage increase also depicted. Specifically, these are the percent differences of the means of femoral neck BMD of the control and treated groups at a given time point. The increase in BMD was immediate, substantial, and durable, even showing evidence of significant increases at the 5 to 7 year mark. As we saw in the patient images, the initial increase in BMD is due to the reflective nature of OSSURE. However, as the implant material was resorbed within the first few months, the BMD drops and stabilizes at a significant higher level than control, since OSSURE is now being replaced with normal bone. We also did a post hoc finite element analysis to determine whether the increase in bone mineral density corresponded to an increase in strength. Because OSSURE is resorbed and replaced by bone, estimates were made about the proportion of attenuated material that should be assigned material properties of bone. 2 assumptions are modeled here regarding the proportion of assigned material properties to bone, between 30% and 100%. It's important to note that in the latter time periods, past 6 to 12 months, OSSURE is completely resorbed and new bone is formed, probably representing a closer resemblance to the 100% bone assumption. Regardless of these estimates used, we see that the increase in estimated strength to the proximal femur is significant and durable out past 72 months. Dr. Keaveney presented these results at the ASBMR meeting, and manuscripts are currently being prepared. OSSURE LOEP was safe and well tolerated. All patients were able to fully bear weight immediately following recovery from sedation. During the first phase of follow-up, there were no device or procedure-related significant adverse events. There was one fragility fracture. A patient fell on the knee of her treated leg with sufficient force to fracture her patella. During the second phase of follow-up, there were still no device or procedure-related significant adverse events. During the second time period, however, there were 6 fragility fractures. There were 2 fractures in control hips, and one patient also fractured her treated hip. In summary, the findings of this initial study support the overall safety and tolerability profile of OSSURE LOEP. From an effectiveness standpoint, the treatment response was consistent across all patients. The treated femurs were immediately stronger due to the OSSURE injection. As new bone formed, there was a substantial and durable increase in BMD. This research and supporting preclinical work makes us confident in the promise of OSSURE LOEP as a new treatment approach for osteoporosis. For more detailed information, you can find the open access link to the published manuscript in the journal Osteoporosis International or on the web via Springer link. Further research is being conducted in clinics in Switzerland, Germany, Belgium, and throughout Europe. The University Hospital in Zurich is participating in a clinical study called RESTORE. This is a global, randomized, prospective, controlled study with up to 50 sites, evaluating whether OSSURE LOEP to preemptively treat bone loss in non-fractured hip in women presenting with a current hip fracture. Anticipation that this treatment will mitigate the risk of a secondary hip fracture. If you would like to learn more about the OSSURE LOEP treatment or the current scientific studies, please contact us at the following address. Thank you for your attention.
Local osteoenhancement with AgN1 is a CE-marked procedure. Its purpose is to reinforce the proximal femur in a sustainable, durable, and biological way. We want to share with you our experience with this procedure in the CONFIRM study. Our hospital is based in St. Nicholas, Belgium, and as with any orthopedic department in the Western European world, we also have to deal with a lot of fragility fractures. The high incidence of fragility fractures is shown on this slide. If you compare certain age groups to the prevalence of osteoarthritis of the hip, the figures are pretty similar. Yet the orthopedic surgeon, as well as the orthopedic industry, is more interested in osteoarthritis rather than osteoporosis. It is also known that the risk for a second hip fracture after you've sustained the first one is extremely high, not only during the first few months, but it stays twice as high even after 2 to 3 years. Based on these data, we felt that we could do a better job for these patients. We wanted to build a better care model for them, as well as for the families. We wanted to address the burden on the families, on the societies in Belgium, as well as the growing burden on our healthcare system. And by doing so, we wanted to establish our hospital as a pioneer in osteoporosis care. This is how we got involved with a study called CONFIRM. The study is a post-market safety study that is collecting all the adverse events as well as serious adverse events of the procedure. We do this in a period 42 days after treatment. The maximum number of subjects to be enrolled is 60. As in any study, it might be hard to find patients, especially to find your ideal candidates. These are the lessons that we learned during the process. Osteoporosis is not seen as a disease, and it seems to be silent, so it's very hard to convince a patient that this might be a problem. You have to be very vigilant during your clinic, and since we're dealing with patients that had a previous fracture, just let them take their time to recover from their first injury. But we found that it was very important as the principal investigator or as the investigator that you have to be personally involved in talking to your patients. In our search for patients, we found ourselves going through several phases. The first phase, which is the review of files, was very time consuming, but it helped us to understand the study. Later on, we identified all patients with a fracture that came through the emergency department, and we specifically looked for them whether they had osteoporosis, yes or no. By doing so, the amount of patients that were a potential candidate for the study increased tremendously. We started to create some confidence in the procedure, as well as having an increased awareness of treating osteoporosis. Because of that, we identified non-fractured patients, and that increased the amount of patients even more. And as you go further down the line, the amount of patients that might potentially benefit from the procedure is tremendously high. So we developed a specific time frame and strategy to deal and talk with patients that were recovering from a fracture. This is a pathway that a patient is going through once he has broken a bone. He will be taken to the emergency department where he is assessed, then he goes to the OR for fracture fixation. He stays in the hospital for a few days, and then he goes home for further recovery. Later on, there's a follow-up clinic at 6 months, 6 weeks, 3 months, or maybe even longer. All these points in time are an opportunity to talk about osteoporosis. We felt that the first time you start talking about osteoporosis might be after the OR when the patient is still in the hospital. This is a time to set up an osteoporosis assessment, and you might already introduce LOEP as a potential treatment to the patient and the family. Obviously, most of the focus is still on the recovery from the fracture itself. In the outpatient clinic, there's an in-depth discussion on LOEP again. We also discussed the benefits, the risks of treating osteoporosis. Obviously, we evaluate the rehab status, and we give the patient some things to think about. In the next visit, that is the time when we decide whether LOEP will be taken place, yes or no. So here are some of our results. So far, we have treated 57 hips in 41 patients. More patients are currently being screened, and this is a multi-center study, so 2 more unilateral hips have been done in other centers. This is an image taken at the time of surgery, where you can easily see the product being injected in the proximal femur. These x-rays taken at 6 weeks and 6 months show a gradual remodeling from the product into what seems to be normal bone. This process is seen in every single patient on every single x-ray. These are the data on pain scores preoperatively and over the 6 weeks following the procedure. To our surprise, there is a steady decrease of pain. This might suggest that osteoporosis is not as silent as we think. Parker mobility score that measures mobility and independence improves for all patients. But if you focus on those patients who didn't have full mobility or full independence to start off with, their improvement was even more dramatic. We did not find any technical issues during the surgery. The kit itself is very sufficient and very easy to work with. OR nurses adapt quickly, and the average skin-to-skin time is about 15 minutes. Our estimated volume of AGN1 that we inject is anything within a range of 8 to 21 mils. These are some of the observations that we made. We didn't have any readmissions or reinterventions. There was no problem with mobilizing the patient. Some of them we put on crutches just for their comfort for the very first days. There's no rehab needed, and we've seen some leakage. There were some minor expected adverse events, such as nausea, pain, and a hematoma at the surgical site. We did have one fatality. On the long term, we had one loss to follow-up. There was one patient who fell again, but we didn't see any new hip fractures at the treated sites. So we noted that there is a high patient interest and satisfaction. Multiple patients were treated unilaterally and came back to us and asked for the second site to be done. Several patients were interested, but were excluded from the confirmed study because of the inclusion and exclusion criteria. So we started to do some commercial cases as well. And it allowed us to set up an osteoporosis center so we could treat these patients not just for their hip, but for their general osteoporotic problem. If you have more questions about LOEP or EGM1, do not hesitate to go to www.agnovos.com. If you have more questions about CONFIRM and the study we are doing right now, please contact us at opvolging@orthokliniek.be or research@orthokliniek.be. Thank you.
Wir hoffen, Ihnen mit diesen beiden Vorträgen interessante Anregungen für die Behandlung der Osteoporose und osteoporosebedingter Fragilitätsfrakturen gegeben zu haben. Ich lade Sie herzlich sowohl auf unsere Kongresswebseite ein, als auch unsere Firmenwebseite zu besuchen, um hier weitere Informationen zu bekommen. Vielen Dank für Ihre Aufmerksamkeit.